Okay, let's talk about some respiratory conditions as we are approaching viral season in the fall. I'm Stephanie Costa. I'm the current MD5 during this fellowship year 2023-2024. So let's start talking about some conditions. So why is this important? It's important because your early patient contact may really turn a patient around and make a world of difference in their care. Your early initiation of supplemental oxygen, albuterol, CPAP, a whole multitude of things could really turn a patient around before they even get to the hospital. So let's talk about some oxygen therapy options that we have on the ambulance, including nasal cannula, non-rebreather masks, and CPAP. Also, the end route of that would also be intubation, but it's kind of for patients who really require intubation, not just because they need some extra oxygen therapy. It's also important to know the FiO2 percentage that you're getting patients with each of these therapies. So nasal cannula, it depends on how many liters per minute you can really get to them, but also it depends on the patient actually being able to breathe through their nose. So it can be anywhere between, 21% if they're just breathing through their mouth and really only getting maybe some low by oxygen by that nasal cannula, up up to probably about 60 to 80%, depending on how many liters per minute you have available to you. Um, Also, you have non-rebreathers and you also have CPAP. With the CPAP, it's very important to note that you may not be getting as much FiO2 as you would like, possibly only getting about 30%. So some CPAP masks have like a little nozzle on the side that you can hook a second tank of oxygen up to bring that FiO2 up further. Or if your CPAP mask that you carry do not have that, you can always have a nasal cannula underneath the mask supplying that second tank of oxygen to hopefully bring up their oxygen sats even further. So let's talk about some different respiratory conditions that people may have. Starting off with asthma. These patients, when you arrive, they're wheezing, they're coughing, they're short of breath, and they can have a mild wheeze all the way up to a respiratory arrest. It's a pretty varying disease, especially because some people may have been having an asthma exacerbation for a while before they call 911. So it's important to recognize a few different things that we'll talk about in a minute. But the pathophysiology of asthma is basically that all the airway diameters are smaller because the smooth muscle in the lungs has contracted. All the walls of your airway are just very edematous. The vessels are backing up. There's a lot of secretions in there, and that all leads to everything plugging up those airways. So there's a lot of extra mucus, cellular debris, protein. Everything's making those airways smaller. So overall, that changes how the lungs get oxygen and blood flow, and this makes the patient have to work harder to breathe. So any possible triggers, such as viral URIs, exercise, environmental contaminants, all of those things can kind of trigger these asthma exacerbations. On exam findings, there's a wide variety. So some may have mild wheezes, some may have very loud wheezes that you can hear from the door, but it's really important to recognize that you may not be hearing any wheezing just because of poor air movement. So if all of a sudden you hear wheezing after they get their first albuterol treatment, it's not that now they have an asthma exacerbation, it's before they weren't moving enough air to make that wheezing sound. Also be aware of the sudden decrease in work of breathing and or altered mental status. This could mean that the patient is heading down a very dangerous route of respiratory failure and would need very careful care and observation from you. Also, something really important to note is that sometimes patients are agitated and it's because they're hypoxic. It's if you are not having enough air go to your brain and your brain was starving for oxygen, you may become agitated too. And it's not that the patient doesn't want your care or doesn't understand the importance of oxygen. It's just that their brain is starving. So that's another thing to be very aware of. So some treatment options include working your way up from kind of mild asthma treatments to severe. Would be your beta adrenergic agents, which is your albuterol, your corticosteroids, which we carry like solumedrol, your anticholinergics, which would be ipratropium. And these work to overall open up those airways. So your albuterol bronchodilates and vasodilates. Your corticosteroids help with all the inflammation. Your anticholinergics also bronchodilate. Moving down to when patients are really having a bad asthma attack, magnesium helps with smooth muscle relaxation. Non-invasive positive pressure ventilation helps with the airflow and the respirations. Just be aware that it can cause hypotension and it can also lead to breath stacking. If a patient is having trouble expiring their air, they may keep on breath stacking, increasing their intrathoracic pressure also. Ketamine helps to increase the circulating catecholamines, same with epinephrine. And then the last resort would be mechanical ventilation, but that's only when the patient can no longer breathe on their own because it doesn't fix the underlying cause at all. Putting a tube down and putting them on the vent doesn't fix their asthma at all. And COPD, this is when you walk in and the patient may be dyspneic, coughing. They may be coughing up a lot of sputum that's different from their normal. They can look really, really sick too. So the pathophysiology of COPD is basically overall, they have a lot of exposure to environmental particles, tobacco, what may have you, and it causes the lung itself to start breaking down, increases mucus secretion, the elasticity of the lung decreases, and all the airways start getting smaller. So it's their lung overall is experiencing a lot of damage. It's important to note that some people may have genetic causes to this. They may not all have used tobacco in their life or been exposed to secondary hand smoke, but some people with alpha antitrypsin disease, they will also have COPD like lung changes that kind of affect the respiration. So exam findings can be a multitude of things: wheezing, tripoding, pursed lip breathing, where they're basically trying to give themselves PEEP with every breath that they take. They could be hypoxic, tachycardic, they could be hypertensive. You may see some cyanosis. They may be getting altered from their work of breathing and lack of oxygen. It's a whole range of things. And your treatment includes a lot of the same treatments as with asthma, with your beta adrenergics, anticholinergics, corticosteroids, non-invasive positive pressure ventilation, and mechanical ventilation. This patient population will also get antibiotics because all the mucus sitting in their lungs and the poor air movement is the perfect breeding ground for bacteria. And a patient knows what their normal sputum looks like. So when they tell you that they have a change, that is concerning for infection. And the next one I would like to talk about would be acute heart failure or any sort of CHF. We do see a lot of CHF population, and they present with shortness of breath, edema, fatigue. Sometimes it's slow where people have been, building up fluid and everything like that for the last week, and now all of a sudden they can't breathe, versus sometimes there's an acute failure where they're having flash pulmonary edema, they're having a hypertensive emergency, things like that. So just be aware they may have been gaining weight over the past week or two that could be contributing, or something may have just acutely happened. The pathophysiology of any sort of heart failure is pretty varied because it mostly depends on what deficit there is, if it's a functional or structural damage to the heart, but overall it leads to poor cardiac functioning. So what happens is in the heart, there's release of some neurohormonal responses when the heart is damaged and not doing well, and that's due to decreased cardiac output. And then those responses lead to damage, lead to water and sodium retention, increase your systemic vascular resistance, which in turn puts a bigger workload on the heart, which further damages the heart and basically perpetuates the cycle until permanent remodeling of the heart occurs. So with exam findings, you may see high blood pressure, you may see pulmonary edema. So make sure to listen to the posterior of the lung bases, because even if the tops of the lungs are clear, there still could be fluid starting to work its way up from the bases. So you may miss an early heart failure exacerbation. You'll see lower extremity edema, JVD. You may have clear sputum production. You may have decreased urine output if they're having a cardiorenal issue also. So there's a lot of signs and symptoms that can really point to a heart failure issue. And other clues may be taking a look at their medications to see if they're on diuretics or any like heart failure medications that may point you towards this diagnosis. Some treatment options include overall make sure that their blood pressure in the airway is supported. A lot of times these patients will have hypertension, but if they're decompensating, they may be hypotensive. You can give them CPAP that will help as long as they are awake and able to tolerate the CPAP and there's no other contraindications present. Nitroglycerin may be an option for some of these patients, but you have to be very careful that they are not experiencing a preload dependent state, which could be they have an underlying right-sided heart attack going on, RV infarction. If they have any valvular disease that makes them preload dependent, such as aortic stenosis, if they have HOCM, which would be the hypertrophic cardiomyopathy, which would also make them very preload dependent. And if overall they're just dehydrated or hypovolemic overall, giving them nitroglycerin can be very bad for them and decrease that preload that the heart really needs. And then overall Lasix is also helpful. It's not going to work immediately though. Outside of pre-hospital and ED care, a lot of times these patients are also on ACE inhibitors, beta blockers, or calcium channel blockers because those help with the workload of the heart, but also with cardiac remodeling. So in case you're looking at their meds, if you see those and they're not sure what type of cardiac condition they have, that can also point you towards the diagnosis. And now let's talk about some other respiratory issues because there are many. So we can talk about anaphylaxis. That is a very severe allergic reaction with at least two body systems involved. So they may have a rash, they may have oropharyngeal swelling, they could have nausea, vomiting, diarrhea, they could have respiratory distress, hypoxia, hypotension, cardiovascular collapse. It can become very severe. You may hear stridor when you first come in, you may hear wheezing. There's a lot of different complaints, and they get treated with IM epinephrine. And they need additional doses and they need to come to the emergency department. This happens due to IgE mediated activation of a lot of different cells, causing a lot of inflammation, leading to histamine release, which overall vasodilates and increases vascular permeability. Prostaglandin D2 release also causes bronchoconstriction, coronary vasoconstriction, and peripheral vasodilatation. So there's a lot of different factors going on. A lot of different mediators get released to cause a lot of these symptoms. So anaphylaxis is not purely a respiratory issue, but you will also see skin involvement, GI involvement. So it's very important to keep a good exam, vital signs, and good observation skills at the forefront of evaluating these patients. For lesser allergic reactions that don't meet anaphylaxis, some medications include Benadryl, ranitidine, steroids, Donebs, Mag, glucagon. But if somebody is having anaphylaxis, they really need epinephrine. Another thing to consider, especially in the little pediatric population, is inhalation of foreign bodies. Sometimes kids eat stuff they're not supposed to. Sometimes it definitely goes down into their lungs. So if somebody has a new onset respiratory issue, always important to keep in mind that there could be a foreign body inhalation. So you may hear stridor, you may hear some respiratory distress. Definitely make sure that there's no batteries around, plastics like plastic bags, small pieces of toys, rubber, latex balloons. Kids like to put balloons in their face. Sometimes when they pop, it can go down their airway. So make sure that you're giving them supportive care, get any care that you need on scene, and transport to the emergency department. If they're unconscious or in respiratory arrest, please initiate resuscitation, and if appropriate, if you can see the object in the oropharynx, potentially try to remove it, but overall call for help and get to the emergency department. Let's talk about angioedema. So that's facial swelling and airway swelling. It can be rapid or slow onset. This could be due to your genes. Some people have a C1 esterase deficiency that leads to this. Medications such as ACE inhibitors and NSAIDs can also lead to this. And sometimes it's idiopathic. We don't know why this happens. But patients can lose their airway quickly, and it will be a difficult airway due to the amount of swelling. So call for help, prepare for your difficult airway, and transport to the emergency department. And lastly, viral and bacterial illnesses. Many of these can cause respiratory issues in themselves, but also exacerbate underlying respiratory conditions. So you want to take a good history and physical exam, wear your PPE so you also don't get sick, and then do your best with your supportive care, any interventions that are needed, and transport to the emergency department. So these are my references. Please feel free to look up any videos or anything like that, and any New England Journal of Medicine also has fantastic videos, along with Merck Manual also has fantastic videos on this. And you can always reach out to me if you have any questions. Thank you.